in child, and what are the management for all those kinds of striders. So currently, firstly, we will define what is strider.
Talent.
Uh, a strider is an abnormal high-pitched sound produced by turbulent airflow through a partially obstructed airway at the level of supraglottis, glottis, subglottis, or trachea. Strider is a symptom, not a diagnosis or a disease. So often, strider is confused by some other noise, airway noise, which is called stutter. Stutter is a low-pitched snoring type sound generated at the level of nasopharynx, oropharynx, and occasionally at supraglottis. So we should not confuse strider with stutter. So types of strider, basically the strider has been divided into three types based on the respiration, phases of respiration. So first is the inspiratory strider. Inspiratory stridor is mainly due to the upper airway obstruction, that is the larynx. If there is an obstruction there, it will cause an inspiratory stridor. The second is the expiratory stridor, which is in the lower airway. When the tracheobronchial obstruction is there, we see a expiratory stridor. And biphasic stridor can be seen at the level of the glottis or subglottic. If there is any pathology in the subglottic glottic level, we see a biphasic stridor. So here are a few causes of acute stridor. So first cause is the infections, which our pediatric colleagues often see in their day-to-day OPD. So it's croup, acute epiglottitis, acute brachial, acute bacterial tracheitis, or and diphtherias. And other causes are laryngeal airway edema, like in laryngeal burns or angioneurotic edema, we can see. To us as a pediatric surgeon, for foreign body bronchus or foreign body trachea, these all are the most common cause that we see in our day-to-day life as a cause of stridor. And other things are a mediastinal tumor compressing the airway, or in tetany also we can have a stridor. So, but we are talking here about persistent stridors in children. So most common cause, as we all know, that laryngomalacia is the most common cause of persistent stridor. But all stridors are not laryngomalacia. So other causes of stridor in children which can be persistent are vocal cord palsy, subglottic hemangiomas, laryngeal cyst, laryngeal web, subglottic stenosis, and tracheal stenosis. So here in further in our talk, we will discuss, we take all these causes and we'll discuss about them. So, but mainly I will concentrate on laryngomalacia as it is the most common cause of stridor, and we often encounter all these cases in our daily practice. So, what is this laryngomalacia? As I have already said, it is the most common cause of congenital stridor in neonate and early infancy. 75% of the cases of stridor are laryngomalacia. So it manifests days or week after birth. It is a benign and self-limiting, that we should keep in mind. It is a benign and a self-limiting thing, and symptom usually resolves by 12 to 18 months of age. So this, what are the signs and symptoms? What the parents come to us with the complaints? So this, that parents usually come to us with complaint of some low pitched fluttering inspiratory stridor. A noise is there. It generally peaks at around 6 to 9 months, and also they will tell that when they keep the child in prone position, the noise is less. And when they're feeding the child or child is active, thus and when the child is awake, thus you can see that noise has increased. It is exacerbated by activity like feeding or exertion. So here is a video. Just I would like to share a case of stridor we had seen in our OPD. So it is a case of severe stridor. So this is the child, you can see having a stridor on inspiration. There's an inspiratory stridor, and also you can see there is severe suprasternal retraction, and also there is subcostal retraction, and there is excessive use of respiratory muscles. So this was the case that we have seen. So further, we as the case was the stridor was very severe, we had to intervene, and we first did a diagnostic bronchoscopy. So in laryngomalacia, we usually see a long omega-shaped epiglottis on bronchoscopy, and also a short aryepiglottic fold. So this is the omega-shaped epiglottis. You can see, which is completely obstructing the airway. It is falling into the airway inlet. You can see, and closing the airway. So yeah, this is the main cause of stridor, as it is at the supraglottic level. So it's on the inspiration, the weak epiglottis is falling into the airway opening. So now the treatment for the laryngomalacia, as I said initially, that laryngomalacia is a self-limiting pathology. So mostly majority of the children are managed conservatively, and few children require surgical obstruction in cases of surgical intervention in cases of severe obstruction. So when we are managing the child conservatively, what we have to monitor for? First thing, we have to monitor that there is a resolution of stridor once the child is growing, and second most important thing is that child is having a good weight gain. As you have seen in that video that I showed you, you can see the child is using a lot of energy in breathing. So most of its energy are drained in breathing. So child will have a failure to thrive, and all those symptoms like that. And also the child will have feeding difficulties, because there will be a suck rest suck cycle. Child will not be feeding properly. So these all things will cause weight loss. So yeah, so we have to look for that in our day-to-day practice. Now, the surgical intervention for laryngomalacia is supraglottoplasty. So it is usually not required. In around 10% of the cases, supraglottoplasty is required. So when is supraglottoplasty required, or when should a physician or a pediatrician should take a help of a pediatric surgeon? So actually, when there is a significant obstruction, there is a severe stridor, as we saw in the previous case, there is severe retractions, there is failure to thrive, there is apnea episodes. That is a very important indication. So there is apnea episodes, or the child develop cor pulmonale or pulmonary hypertension. So this is the time when the child requires an surgical intervention. Surgical intervention is basically a supraglottoplasty. So next, yeah. So here we see the surgical supraglottoplasty, how it is being done. You can see this is the epiglottis, and the fold which where we are cutting, it is the aryepiglottic fold. Usually in laryngomalacia, these aryepiglottic folds are very short. This is lower down is the arytenoid here. So these aryepiglottic folds are very short, and this causes the prolapse of the epiglottis into the airway. So we just give a little cut and increase the length of that aryepiglottic fold. So basically what we are doing, we are relieving the obstruction, the upper airway obstruction, what is there, that we are relieving by increasing the length of the aryepiglottic fold. So it is done bilaterally on both sides, as you have seen, we have done. So now this is the same child that we had done initially. That child presented to us with stridor. Now after supraglottoplasty, this is the child. It's all calm. The stridor has gone, but it's not always the same. This same magic. It won't happen every time. The child will. Eventually, we have to what we have to consult the parents. Is that after the procedure also there will be some stridor, and eventually the child, when the child grows, child has good weight gain, these stridors and things will settle down. Immediately this stridor will not go. And also as we have as I have been telling that we are reducing we are relieving the obstruction of the airway. So the thing is that when you relieve the obstruction in children, there are more chances of aspiration. So we have to look for that also. The child should not have aspiration. Child should be on some anti-reflex measures. In our day-to-day practice, we use domperidone and Rantac for this. And yeah, we have to monitor again on follow-up. We have to monitor how the child's weight gain and things. So, as I told, stridor, there is in 75% of the cases, laryngomalacia is the cause of stridor. So, what about the next 25% case? So 25% causes of this stridor. So first we will discuss about bilateral vocal cord palsy, which is the second most common cause of stridor in children. It is mainly because 10% of the congenital laryngeal lesions. It may be congenital or acquired, and most often it is idiopathic. So it is a very serious. It is a serious entity. It child usually has a aphonia and a high pitch biphasic stridor that may progress to severe respiratory distress. And these children are usually associated have associated CNS abnormalities that also we have to look for. And usually these will resolve within 24 months when the child is has good weight gain and child has grown. So what we see on a bronchoscopy in bilateral vocal cord palsy, the vocal cords are in paramedian position that causes the obstruction. There is no movement of the vocal cord. So what we do in severe cases, what we do for bilateral vocal cord palsy, the surgery is called vocal cord lateralization. So we open up on any either side, right or left. We lateralize the vocal cord, and yeah, now you can see the airway, open airway, and this is the follow-up scopy image that you can see where the airway is better than what it was before. Yeah, here also, as we have opened the airway now in children, so there are risk of aspiration, but eventually the child outgrow those all things when the child has grown well. And yeah, we need to keep the child on this anti-reflex measures post-operatively. And also the weight gain and risk of infections we have to look for in follow-up. The next cause is laryngeal web. It is usually an incomplete recanalization of the laryngeal lumen during the embryogenesis. Most in severe cases, it occupies almost 75% of the glottic area, and it is mainly in the anterior part. It presents soon after birth. The child usually presents with weak cry and biphasic stridor. So this subglottic stenosis can have associated laryngeal webs can have associated subglottic stenosis with them, and also it has a syndromic cause also. So that also we have to look for that in the in children with laryngeal web. So the laryngeal web in the diagnostic endoscopy is required to rule out other abnormalities. As I said earlier, that subglottic stenosis is very common in these children. So we have to rule out other abnormalities. If the laryngeal webs are there's not much of obstruction around the grade 1 or grade 2. I mean, it is around 35 to 50% of obstruction is there. Yeah, there is we can wait, or small interventions like laser and all we can use to relieve the obstruction. But if there is a significant obstruction, if there is a significant obstruction in the newborn period, child may require a tracheostomy. And laryngotracheal reconstruction, which can be done if there is a severe stenosis, a severe webbing is there. Laryngotracheal reconstruction is done. So next, coming to laryngeal cyst, it is also it is a rare cause of stridor, but yeah, we see cases like laryngeal cyst. So it presents soon after birth. Site is in the supraglottic region in the epiglottic fold, and the child present with stridor, hoarse voice, or aphonia. And sometimes cyst may be large enough that it may occlude the airway lumen. And these cysts usually contain mucus from the minor salivary gland. So here is a cyst. You can see a laryngeal cyst. These are the vocal cords, and below the vocal cords, you can see the cyst is so much big that is it is impinging on the airway and causing an obstruction. So, what is the treatment for this? What is the treatment for laryngeal cyst? Basically, if the cyst is small and things, we can try to take it out completely. But if the cyst is very large, cyst can be marsupialized. So, here is a video. can see this cyst is very huge, and epiglottis is almost somewhere down there. So this all bronchoscopic procedures and things are done with a suspension laryngoscope. We have this equipment called suspension laryngoscope. It is done. So we are just opening up the cyst here, as you can see, with the cautery, and as the cyst open, you can see that this all mucinous fluid from the minor salivary glands, what that the content of the cyst comes out. As this cyst was very large, so we plan to marsupialize it. Yeah, you can see that the content of the cyst that is coming out. So the next common cause is laryngeal hemangiomas. Laryngeal hemangiomas are also very rare in the glottic and subglottic area, but cases are there. Usually it is submucosal. So, but in 50% of the cases, there will be a cutaneous hemangioma in the head and neck region. So, if a child with stridor presents to our clinic, and we see there is a hemangioma over the face or neck area, we should suspect about laryngeal hemangiomas. So laryngeal hemangioma, it presents with inspiratory or biphasic stridor that as it may be uh, in the subglottic region, and it may worsen as the lesion become engorged with blood vessels. Typically, the hemangiomas present in the first 3 to 6 months of life during its proliferative phase and regresses by the age of 12 to 18 months. The hemangioma has his own natural course. So when the hemangiomas are in the proliferative phase, then only these children present with airway obstruction symptoms and stridor. So as you see, this is the subglottic area. There is a hemangioma which is causing significant airway obstruction, and which results in stridor. So treatment options for hemangiomas are consist of oral steroid or intralesional steroid. Laser therapy is also recommended. And lastly, if these things doesn't work, surgical resection can be done. For hemangiomas, propranolol is a wonder drug we use in our daily practice. But it is contraindicated in children with severe asthma, diabetes, and heart disease. We usually admit if the children with hemangioma present to us, we usually start them on propranolol. We admit them, start on a lower dose, and slowly upgrade the dose to the maximum dose. And this is done under continuous monitoring. And if the child and things are stable, then we discharge them on propranolol. And we follow up the child with regular size of the hemangiomas with regular photographs. And also, if the child had stridor, we follow up with how the child has symptomatically improved. So this is one of the cases of hemangioma, or a child on propranolol therapy presented to us with stridor, and there was a cutaneous hemangioma marker for that laryngeal hemangioma. So after this propranolol therapy on follow-up, the hemangioma has almost regressed, and the child improved symptomatically also. So next cause of stridor is stenosis. So first, I will talk about subglottic stenosis. Subglottic stenosis can be acquired and or can be congenital, but acquired subglottic stenosis are more common. We usually and it is very difficult to manage. We usually see these children after an endotracheal intubation, traumatic endotracheal intubation. So if a child presenting to our clinic with some stridor, and parents give the child has a history of intubation, or the child had some illness in the past requiring an ICU care and on ventilatory support. So we suspect this kind of acquired subglottic stenosis in those children. As the cricoid area, subglottic area is a it's the narrowest part of the airway, so it is more prone for a trauma. And when the trauma, these traumatic intubation, when they heal with scarring and cause subglottic stenosis. So usually stenosis, if it is a low grade stenosis, you can see this airway is almost more than 70% open. You can see there's a flimsy layer, that these layers, fibrotic bands, are not much thick and hard. So these stenosis are amenable for bronchoscopic dilatation, balloon dilatation we do. So these are amenable for dilatation. But if it is a chronic stenosis, if it is a high grade stenosis, and also if it is a congenital stenosis, they won't respond to balloon dilatation, and for them we require a surgical intervention. So we'll discuss further what is the surgical intervention. So yeah, subglottic stenosis, low grade, MLB and balloon dilatation can be done. So balloon dilatation usually it's done in intervals. After every 3 to 6 weeks, we see how the after the first dilatation, how the child has improved symptomatically. We do a check bronchoscopy. If the child is asymptomatic, then also we do a check bronchoscopy. If the child is symptomatic, we do further bronchoscopies, and if required, dilatation. Usually three sitting of dilatation we do. If the child does not respond on that also, if child has recurrent stenosis, then child may go for a reconstruction surgery. And when the subglottic stenosis are high grade, when the bands, the stenocydia is very fibrotic, not amenable for dilatation, then we do, and also if it is a congenital one, we do a reconstruction using a costal cartilage graft, or we remove the stenotic area and do a cricotracheal resection and anastomosis. So this is the yeah, as you can see, this is the video of a child with subglottic stenosis, around 70% stenose area, and you can see it is a low grade stenosis. Here we have introduced the balloon. You can see the balloon and inflated the balloon. If we inflate the balloon according to the size of the airway, as per the age, different pressures are there which inflate the balloon at appropriate size. And you can see after the dilatation, the airway has opened up nicely. So yes, so this is again stenosis, and this is the result after the dilatation. So this is a very high grade stenosis. As you can see, almost a pinhole opening is there in the airway at the subglottic level. So yeah, so treatment for the our treatment option is primary goal is to achieve decannulation. If the child if the child has present to us on tracheostomy, the primary aim is to do decannulation by either doing a balloon dilatation if it is a mild stenosis, and or to prevent a tracheostomy. These all things are possible if the child has a mild stenosis. And if this child has a temporary, if the child has a severe stenosis, child has failure to thrive, child is not having adequate weight to undergo surgery and things, then we, for temporary thing, we do a tracheostomy. Most of in here in our hospital we have a big cardiac center, so children with all those cardiac issues, they'll require prolonged ventilation, and they also have other comorbidities with the cardiac and things. So at that time, temporizing measure is the tracheostomy, and later when the child is out of all this thing, we plan for a airway reconstruction for them. So yeah, this is a diaphragmatic surgical procedure. What we told is balloon dilatation, and second is the anterior cricoid split. We split the cricoid anterior on the anterior part, and a costal cartilage graft, as you can see, has been put in between, so that it increases the size of the lumen of the airway. And the thing is, if the stenotic segment is small, it's a not it involves one or two tracheal rings, then a resection of that stenotic area can be done, and anastomosis later on. Anastomosis in the same. So now coming to the tracheal stenosis. So tracheal stenosis, mostly we see it is congenital. So congenital tracheal stenosis usually presents with complete tracheal rings are there. When we see a normal airway, there is a cartilage C type cartilage is there. It is not a complete ring, and posteriorly you can see that membranous part. So, but here the airway whole airway or a part of airway, means trachea, is replaced by complete tracheal ring, which causes obstruction. These children usually present with stridor, and this necessitates surgery if the child is very symptomatic. So the surgery for this complete tracheal ring is slight tracheoplasty. Uh, if the if the tracheal if the stenotic segment involves whole of the trachea, then we do slight tracheoplasty. If the stenotic segment is limited to one or two rings of the trachea, that seen on the bronchoscopy previously before starting the procedure, so then we do resection anastomosis. If the stenotic segment involves whole trachea, we do or slight tracheoplasty. We expose the complete length of trachea, and here you can see after opening the trachea, you can see that there is a complete ring of cartilaginous ring of in the trachea. So we have exposed the trachea. This case usually had a whole of the trachea was replaced by this complete ring. So yeah, we have to do a slight tracheoplasty. We give an incision on both sides of the trachea, and the anastomosis is done so that it increases the lumen. Although it shortens the length of the trachea, but it increases the lumen and have an adequate result. Other cause of stenosis can be extrinsic cause. Mainly, it is associated with all those children with cardiac anomalies and cardiac disease. So here we see few children with this thing. So extrinsic causes of stenosis are vascular rings, slings, and a double aortic arch that encircles the trachea and the esophagus. Here you can see that airway is compressed by the double aortic arch. So my carry home message from this talk is that a stridor in infant is not equivalent to laryngomalacia. There is high index of suspicion for diagnosis, and a good MLB should be done if there is the suspicion of causes other than laryngomalacia. And usually these children will have good results with surgery if it is a severe case. Thank you.
Thank you, Dr. Pallav. You can stop the screen sharing so that we can have some discussion now.
Yes.
You can completely stop the screen sharing and put on your video. Your video is off. Hello, can you hear me? Yeah. All through the talk, your video was off, but I thought it was intentionally done. Thank you very much, Dr. Pallav. In spite of the initial 15 minutes of technical glitch, you more than made up for it. It was very heartening to see a young pediatric surgeon presenting such marvelous cases. Such, we hear that not many people are now taking up pediatric surgery, but very happy to see a young pediatric surgeon presenting unusual cases, because we do talk, we hear a lot of pediatric surgeons, but not many of them talk about upper airway surgeries. So really very nice presentation. And now we are open for discussion. And Jagdish, Dr. Jagdish Sinappa, also from Bengaluru, is an expert in upper airway, and we expect some comments from him. Dr. Jagdish.
Thank you. At the outset, Dr. Pallav, congratulations. Very nicely presented, beautiful cases and beautiful videos. Very nice. Thank you. And I think he's following his mentor's footsteps. I think Narayana Hridayalaya had one of the first very good airway reconstruction centers in Karnataka, and Dr. Rao was there, who was doing. I'm sure he's still there, if I'm not mistaken. You're not. I can't hear you, Pallav. I can't hear you.
Under him only I've been doing, sir.
Yeah. So he's one of the pioneers in airway surgery.
Yeah, under Dr. Rao, only Dr. Rao and Dr.
Yeah. So that that gives, and he has been for so many years presenting this airway reconstruction and this difficult airway problems, which is really heartening to see. I just want to go back to a couple of comments. The first comment is yes, laryngomalacia is the commonest cause of upper airway obstruction, and the point which is very important to note is you have to always look at the voice. Is there a change in the voice? Because if you don't, from the nature of the sound, you can make out where the obstruction is.
Yes,
And
yes.
if you have a voice which is affected, if the child's cry is
Where the
affected,
obstruction.
then you are
Yes.
mostly onto laryngomalacia. Whereas if you don't have a voice involvement, there's a problem. The second point which I wanted to make was, if you look at the video that he showed of laryngomalacia which was operated on, there is another very interesting abnormality in that child, and that is a significant retrognathia. That is a jaw which is going back. Now, if you have a jaw which is going back, in addition to laryngomalacia, obstruction will be more severe, because you will have you will have a reduction. You'll have a reduction in the posterior pharyngeal space, or the space which is where the air flows. So that is the second thing. The third very important thing is, when you're operating on these children, you have to talk to the parents and convince and tell them that the child is not going to be noise free. You might improve it. The child's breathing may improve, but the noise will still continue for a long period of time, because you cannot completely correct the laryngomalacia. You're only alleviating the severity. So these are some of the points that you need to be very clear before, when you're talking to the parents about surgery. Of course, the others are exotic disorders, which are rarely the thing. The other point which we also mentioned was propranolol. You might also want to see if there is a hematoma in the palate, because sometimes you may miss a palatal hematoma, which is also associated with a laryngeal hematoma. And we don't use steroids at all. Our standard of care is propranolol. And we just avoid steroids in children because of the growth issues and other complications.
Our standard of care is also.
Thank you, Dr. Jagdish, for very useful comment.
Thank you.
Now, house is open for others for their comments, questions, queries.
Thank you, sir.
Pallav, how does propranolol help? What is the mechanism?
No, mainly it's decreases angiogenesis and all those things. It has been proposed that. So it helps in the proliferation of blood vessels, whatever is there. It will decrease that.
Does the congenital large lymphangiomas and lymphocytes obstruct? Because we have seen that they are non-obstructing despite of their sizes.
No, sir. Sometimes definitely they can obstruct, but usually large lymphangioma, if it is entering into the mediastinum, upper mediastinum, definitely it causes obstruction. But once the lymphangioma and things are surgically handled, the stridor and things will settle down.
Another thing is a subglottic lymphocyte, small lymphocyte, which many years back endoscopists like you just cut it open and patient recovered it. 1 week old child. Well, I am an adult surgeon. I did a series on tracheomalacia, avoiding tracheostomy by using nasopharyngeal soft tube 30 years back. Nasopharyngeal soft tube will avoid upper airway breathing disorder and allow the trachea to heal, but that was in adults. Post large thyroid, external compression. Another thing was Dr. Krishna Rao many years back used to treat tracheomalacia and tracheal strictures post cardiac surgery by laser luminization, by cutting the O into C.
But here we, in our practice, we don't use laser in the airways. Actually, we have seen many cases where laser has been used for this recurrent tracheoesophageal fistula. They will use laser to cause that the fistula on the tracheal side, and it leads to a massive big tracheal defect later when it usually does not heal very nicely. So we don't recommend use. We are not using lasers here in this in the airway.
Pallav, unfortunately, we can't hear you well because it seems the connection is unstable because your video is on. Probably the bandwidth is coming short. Anyway, any other questions or comment?
I think there are Dr. Pandya. I'll just read out. There is a question in the chat box
Okay, please.
on how often do patients of autism have difficulty in speech and have upper airway anomalies, from Dr. Manoj Yadav.
Autism having difficulty in speech and have upper airway abnormality. Jagdish, you can answer this. Autism is our subject.
Yeah. So basically, many of these children will have upper airway obstruction, and that obstruction is due to various causes. It is not only because of autism itself, but because basically they have incoordination in the upper airway, and they also may have other issues like, for example, adenotonsillar hypertrophy, obesity. All these things have happened in autism primarily because they are not very active, and they are not physically active, so they tend to put on more weight, and because of that they generally have upper airway obstruction, which is a totally different story. It has nothing to do with the larynx or the airway there, but it's basically tonsilloadenoidal obstruction which causes a problem in these children. Now, I just wanted to just bring forth two more important points which other may you find interesting. We have been looking at ultrasound to diagnose laryngomalacia, and we have been using laryngeal ultrasound, which is it's still in its infancy. We are not very clear how to use it, but over time, I'm sure every practitioner who is doing POCUS or what is point of care ultrasound can probably diagnose laryngomalacia in his clinic by just looking at the ultrasound images, because it's dynamic. You can see the flop of the epiglottis into the cord, and you can make that out. That is one. The second thing is also a very interesting thing of artificial intelligence, analyzing the noise which the respiratory tract makes and giving you an approximate anatomical delineation of where that noise is coming from. So people are working on this to collect this information, just because there are more than 50 different sounds which come from the respiratory tract. And depending on the nature of that sound, whether it is inspiratory, expiratory, on its pitch, volume, etc., you can probably, with AI, come to a reasonable conclusion of where your obstruction is. For example, if you have a child who's got let's say a vascular ring, the stridor is entirely different from that if you get from a tracheal stenosis or a subglottic stenosis. So I think the important thing is, over time, we are going to get all these new technologies in, which will non-invasively tell you where the obstruction and what needs to be done.
Good to know about these developments. Good. So I think we can end the session here. Thank you, Dr. Pallav. It was wonderful presentation. And Jagdish said, very heartening to see a young pediatric surgeon doing all these things and nicely presenting it. So thank you very much. Thank you all for participation. Once again, we regret the delay because of technical glitches beyond our capacity to handle. So please bear with such technical glitches when we do the things online. Always, sometimes it does happen. So please bear with us. So we meet next Saturday morning again. Till then, goodbye. Thank you.
Satish bhai, you have finished early today despite starting late.
Yes, because Pallav was brief and comprehensive and very useful.
Absolutely.
Thank you,
So,
Pallav.
thank you, Dr. Pallav, and thank you, Satish, and thank you all.